Mr. Afzal. Or maybe you can talk about the FRCS urology exam and how that is conducted, because the format has become different now from what, because we used to follow the FRCS exam, the typical long case, short case, and OSCE. The format is the same for FRCS nowadays.
Is it to me, Hammad? You're asking
Yes,
me?
yes.
Yeah,
Yes,
yeah. Yes, I think the format is similar, and I would say like a FIBU, European Board Urology, is more like in a way similar to what you guys are doing. FRCS Urol, yeah, similar, slightly more. I think comparing two, I can compare FIBU and FRCS Urol, the European Board.
Yes.
I guess European Board is more objective in the sense that there are less examiner bias, and there are set number of questions and they've got set number of answers. There can always be more than one answer. And if they have answered the question one way or the other, A, B, or C, whatever, there can be always more than one solution. So then it's more like, I would say, objective analysis of the exam. I've taken both long time ago, but I would say, one time I would like to come and attend one of your exams and see, how you guys conducted there. And yeah, and I will be able to compare.
Perfect. Thank you very much. I think Imran is ready with the cases.
Okay.
Please feel free to share your comments as we go along. And Mr. Afzal is here. He's going to address all those questions, and I can also pitch in if needed. So Imran, the floor is yours. Please go ahead.
Can't hear Imran yet, maybe.
Imran?
This? We can see his slide.
Unmute me. Please unmute Imran. Is he muted?
Dr. Hammad, can you listen me now?
Yeah, we can hear you.
Yeah,
please go ahead.
We can hear.
Thank you, and salam to everyone. Thank you, Dr. Hammad, for giving me an opportunity to present a few cases which are very interesting to me and for the resident point of view. So I'll start with a few questions in mind of every urologist or trainee urologist when he or she is treating the prostate cancer. So these are very pertinent questions. They must be answered
sorry,
before
Dr. Imran, Dr. Imran, can you please click on that full screen mode?
Full screen mode. This one? Full screen. No, or yes. Yeah, this one?
Yeah, we can see you are on the full screen.
So the interesting questions which are very important: do we treat it now? How to best treat it? And should we treat it in a way that it should be curative or palliative? What are the chances of recurrence or progression after any definitive treatment? And what if there's a recurrence or progression after definitive treatment? So these are very important questions should be kept in the mind before going on for any prostate cancer treatment. So I'll start with an organ confined case. So he was a 62-year gentleman, hypertensive with ECOG 0, no bothersome lower unit tract symptoms. So his PSA was done by general physician, which was 5.8. And on a DRE, we noted a 1.5 centimeter nodule in the left apex. So my question from the resident's point of view would be how to proceed. Will you go for the biopsy first, or MRI first? I think they can answer on chat box. So we went ahead with the MRI, and we can appreciate that this on the right side top corner top, you can see that a couple of nodules which are visible on MRI. Clinically, it was T2A. Now MRI, it's a T2B without any node involvement. So intrascated by, yes, Dr. Hammad.
Yes, no, sorry to interject, but what is the personal preference in UK? How do you go about? Do you do an MRI first before histologies?
Yeah. You know, Hammad, for the resident information as well, things are slightly different here. So anyone who gets referred before he is seen by a clinician, they fulfill the criteria. And if they are in that age group where they can have their treatment, then they have their MRI first. So they have multi-parametric MRI with contrast enhanced MRI, which is gadolinium. And then they come. In fact, their MRI is discussed in the multidisciplinary team meeting even before they see a clinician. So already a decision is made by a panel, radiologist, urologist, consultant. So even if they're seen by in a way registrars, they've got a plan that what we need to do. And here I can see that a patient had 2 core biopsies. We do it differently here in Dorset. Every patient, we don't do transrectal biopsies anymore. Everybody gets transperineal template biopsies.
Imran, please go ahead.
Yeah, so this patient went to 12 core transrectal biopsies, out of which only 2 core were positive. And I wanted to ask the ISUP grade, and residents have already answered this question. It is grade 2. So further metastatic workup, bone scan was negative, MRI was negative for any lymph node involvement, is T2B, N0, M0. So what would be the definitive treatment for this gentleman who is a 62, hypertensive, ECOG 0?
Can I just say something here? You know, in this case scenario, if the PSA is under 10 and if they've got intermediate Gleason 3+4, we don't routinely offer bone scan, because MRI scan gives you enough information in these intermediate grade cancers. We reserve bone scan to high grade cancer, Gleason 8, 9, or if their PSA is over 15.
So the literature does suggest about PSA more than 15 or 20 to get bone scan done. Otherwise, one can omit. Yes.
Yeah.
Thank you for adding this point. Yeah. So in order to further pursue the treatment, one has to categorize each patient with a risk group. Either this is low risk or intermediate or very high risk. So depending on that risk group, we should categorize our treatment plan. So what options do residents think would be suitable for this gentleman? So Anwar Ahmad is saying that radical prostatectomy, why not active surveillance? Low risk, PSA less than 10, Gleason 7. So these are certain nomograms which are available and which has been available since long, like a Catan's nomogram, Parton's table, in which if you place a data, you can actually predict what are the chances of this patient to have organ confined disease without extraprostatic extension or not. So this is important clinical data. If you put in, an important thing is that clinical stage is the stage you already have determined by doing a DRE. This does not include MRI staging. And once you decide for radical prostatectomy, one has to be very careful in a young patients for trying their level best to preserve the nerve sparing. But a few questions in the literature, if you see that there are few questions to be answered, for eligibility criteria for nerve sparing procedure. For the nerve sparing procedure, either unilateral or bilateral, one has to be T1 or T2 prostate cancer with a low risk group, which already we have defined.
What is your criteria, Mr. Masood? What about the nerve sparing? Do you offer it?
Yeah,
to everyone?
you know, yeah, we assess every patient, and all patients who have got reasonably different scores are used, you know, SIM score, SHEM score, and if they have got reasonable erectile function and they want to preserve it, then we do offer nerve sparing. We, in this case, you know, probably will offer bilateral nerve sparing. But then, as you say, you know, our biopsy criteria is more detailed. And if this guy's, for instance, if he has got a 40 cc prostate, he'll end up having 40 biopsies. So we biopsy every 5 millimeter, and then we get a map. And then in looking at the map, we know exactly where the tumor is, and then we decide if the tumor is too close to the periphery. So we go wide on that side, wide axion, and on the contralateral side, if the tumor is away from the periphery and we can safely do nerve sparing, so we offer that. And in this way, we offer, sorry, we can, majority of the cases, over 90%, we can avoid any positive margins.
Thank you. So, sir, one question: these are saturation biopsies, or image guided biopsies by all means?
Yeah, so this is like different centers do it different way. We have got, if you can search, we have got our own like a Dorset criteria where we do consider the MRI scan. So we are not doing MRI fusion biopsies. You can either do MRI fusion biopsies where your MRI scan, where the lesions are, a pyrite 3 or 4, which you can put it on your, I guess it's not possible with truss biopsies that easily, but transperineal biopsies, you can superimpose that view. And while you are doing a biopsies, you can precisely locate that lesion. Now, what we do, we have got that information, but because we are running we are doing a study where we are considering how accurate multiparametric MRI scan is. So we do, irrespective of our MRI finding, we biopsy every 5 millimeter of the prostate. And then we generate a map which tells you the location and Gleason of every 5 millimeter of the prostate. It comes in a view. I mean, I could show you our map, and then you have the detailed information that sometimes with MRI, you know, yeah, they are quite sensitive, but sometimes you miss. So in a way, we have found in our pathologists happy that we do it once for all, every 5 millimeter, because what's in between 5 millimeter is not significant. So we don't miss any lesion, and our chances of negative biopsies are negligible with this. So it's a different technique. Just answer to your question is, one is MRI fusion biopsies, one is saturation biopsies, but we do every 5 millimeters. So this is detailed map of transperineal prostate biopsies.
Thank you, sir. So moving on to organ confined disease, again in a different age group. So 78-year gentleman who is ECOG2, known case of diabetes, hypertension, ischemic heart disease. He had a urinary retention which was refractory to prostate medical therapy. Rectal exam did not show any nodule, not a big prostate, but obviously on transrectal, I mean a TURP specimen, 30% of chips are involved by adenocarcinoma, and as already answered by residents, this is ISUP grade 2. His PSA turned out to be 18, and bone scan is negative for the distant disease. MRI shows T2A, less than half of one lobe is involved. So now it's a what's the management option for this gentleman who is a 72 ECOG-2 with hypertension and ischemic heart disease. So one of the residents said the EBRT, that radiotherapy, other is pointing out towards radical prostatectomy. So coming up to next. So one can consider a deferred treatment in such an age group. So once you decide for a deferred treatment, you must know that what is the expected life expectancy of that gentleman who is 78 ECOG-2, and then you tailor the treatment according to the needs of that patient. And for residents' point of view, this is very important to note that the difference between active surveillance and watchful waiting. Intention is totally different in both of these treatment arms. One is curative disease. Other is just treating the symptoms whenever they appear. So this gentleman does not have a life expectancy of more than 10 years, hence watchful waiting would be an appropriate option for this gentleman. So this is a very interesting case of the young male who came in May 2014 had a locally advanced prostate cancer. So let's go ahead with this. So 42, father of one kid with acute urinary retention and hardly lower tract symptoms, which were started 3 months before. He's ECOG-0. On the rectal exam, nodular prostate with a bilateral seminal vesicle involvement, at least T3B, PSA turned out to be 68 nanograms. And multiparametric MRI shows it's a T4 involving the bladder neck, bilateral capsular invasion, seminal vesicle involvement, and regional lymphadenopathy on the right side. The largest lymph node is around 8.2, which is obturator 1. Bone scan is negative. Transrectal biopsy shows Gleason 4+3 with lymphovascular invasion and perineural invasion. So remember, he's 42 with locally advanced disease, MRI node positive. So to summarize, 42 ECOG-0, acute urinary retention, catheter in place, PSA of 68, adenocarcinoma 4+3, and MRI is a T4 and 1. So what are the options? Arsalan is saying that it's EBRT. What about retention? He is in retention. And if you go back and see MRI images, that the catheter is being pulled on the one side because of large median lobe, or you can say that the large prostate cancer. So because of his young age, multimodal treatment, he was obviously detailed discussed with every options, and he basically agreed with multimodal treatment, which was radical prostate. It was basically salvage prostatectomy rather than radical prostatectomy, and followed by EBRT and hormone therapy. So he underwent radical prostatectomy on March 14. Histopathology came out more than 95% of gland is involved by the tumor. 8 out of 12 nodes were positive. Bladder base plus left, at least 3 or 4 margins are positive. And post RRP, his PSA is 0.16. So what's next? As it was planned for the EBRT, so he was started on external beam radiotherapy, which was 66 gray, June to August 2014, and then LHRH analog only. He remained like very well till December 2017. Till then, his PSA was 0.04 nanograms. In January 18, the PSA 0.3 was noted. And then subsequent in April, we can see that it's 0.63. So what next?
While the residents are exercising their vote, I have two questions to Mr. Afzal. Number one, is there an age cutoff to robotic or open radical prostatectomy in your practice, providing that his medical condition and fitness allows?
Yeah, so it's simple. My cutoff is 75. Because anyone who is below 75, and if they are fit and healthy, I offer them robotic prostatectomy. Anyone over 75 goes for radiotherapy or brachytherapy, depending upon the size of the prostate. But this guy, Hammad, going back to this case which is being discussed, this patient, there
Yes.
are always more than one way to treat. But I wouldn't have offered him prostatectomy because we are aware that this guy has had micrometastatic disease, he's got lymph node involvement, and now guess what he had is prostatectomy plus additional salvage radiotherapy, and I'm pretty sure 99% he would be incontinent. If he is not, I would be pleasantly surprised. So in this case scenario, I would have done a PSMA PET scan on him, which in our practice is available. So then we would have known which lymph nodes are positive, and I would have offered him with our radio-oncologist extended radiotherapy covering those lymph nodes which are involved. And along with that, we would have offered him channel 2 URP to get him going. So in that case, he would have one treatment rather than two, which wasn't curative intent, and we would have resolved his acute retention issue. So preserving his continence, getting him going, and just treating him with one treatment, with other treatment which wasn't required in this case.
I totally agree with you. I think radical prostate or prostatectomy, not really radical, was probably not indicated here. We know that he's young and he has got a very aggressive cancer, but radical prostatectomy added very little to the management of this young man. Thank you. I agree with you, Mr. Afzal.
Yeah.
Thank you.
Okay, Imran, proceed.
So we had a PSMA. Remember that this guy came in 2014 March, and then recently in 2018 gotten a PSMA scan that showed the left para-aortic node, which was 1.2 into 1 centimeter with SUV of 7. And then he was started in abiraterone acetate and prednisolone, which is now CRPC now. So if you see the overall progress so far, so in March 30 till even 18 January, he was okay with hormone therapy only. Then PSMA was done, and it was combined with complete androgen blockade. So Dr. Hammad, do you think in current era, complete androgen blockade has some value in these type of cases?
Well, the hormone treatment scenario has changed significantly over the last 4 or 5 years. And what my old practice was that these hormonal agents, and we used to have very limited access. We used to have the LHRH analogs and then oral anti-androgens. That's what we had. And I tend to use them very carefully and only start off with LHRH analogs if the PSA doesn't drop below 4, and there is good quality data indicating that if it stays over 4, the 5-year survival is poorer. Add with anti-androgens. But now there is a very strong data indicating the use of abiraterone or enzalutamide much earlier. And in fact, the docetaxel is also coming up quite early rather than as one of the last few treatments. So things have changed significantly, and my practice has also changed. The only issue sometimes is that the use of these second-line agents, abiraterone or enzalutamide, and some of the other newer agent cost is a major issue.
Yeah, Hammad, that's a very good overview of these hormonal treatments. I would agree with you, and especially if they are a younger patient and they have got aggressive cancer with high PSA, especially Gleason 8, 9, and 10, then our oncologists would, they get involved and they would offer either they go on taxanes, docetaxel, or they go the second line treatment with enzalutamide or abiraterone. Going back to this case for the interest of the residents, now this chap, if he had a PSMA PET scan which showed a solitary node, para-aortic, we had a case report published last year in British Journal of Urology. Sorry, it was Journal of Clinical Urology, yeah, where I did a robotic prostatectomy on a young man. He had Gleason 8 prostate cancer. PSA was, I think, 10 or 12. He had negative margin, but he still have a detectable PSA. Usually, I expect that after negative margin, the PSA drops to less than 0.01. So in his case, his PSA was 0.1, so which is quite high, 10 times what I was expecting. So we did a PSMA PET scan. To our surprise, he had a one avid node about 1 centimeter para-aortic. I did his lymph adenectomy and all his pelvic lymph nodes, we took 17, they were clear. But there was just one node at a para-aortic higher up. So we offered him a cyber knife. We treated just that with localized radiotherapy, and his PSA is undetectable since then. So in these cases, if somebody has got like a solitary node, and I guess in Karachi you have got this cyber knife available where they can be considered for that treatment. It's solitary node.
So thank you for adding this.
The way the spectrum has changed is the liberal use of imaging.
Yeah.
With the addition of PSMA scan, and prior to which the PET choline, which is obviously inferior to PSMA, the liberal use of CT imaging and MRI. So all these things have changed our viewpoint, because otherwise, if you have not done a PSMA, you probably would not have been able to pick this node on the regular CT imaging. So Imran?
Yes, sir. So for the resident's point of view, this is important that the PSA sensitivity is related with the serum PSA, even though this in current data, this might not be true, but this is how the guidelines suggest that if PSA is more than one, PSMA is 75% sensitive in picking up these hypermetabolic avid nodes. So for these young people who have a strong family history of a tumor, or young patients who are diagnosed with a prostate cancer which is aggressive, one can consider these germline mutation, especially for residents. This is exam point of view. For their clinical implications, they still have hardly any implication in management point of view. But however, these germline mutations can be considered for these patients. So this is again a locally advanced prostate cancer. He's a 56 male, no known comobs. He's a businessman by profession, ECOG 0. He had minimal symptoms like penile pain for hardly 2.5 months. And his PSA, which was done outside, it came out to be 44.46. And you can see the DRE shows a T2C lesion. On an MRI, we can appreciate that this lesion is involving the bladder base. And extract prostatic extension you can easily see. His bone scan was negative, and biopsy, which was 12 core biopsies, showed a Gleason of 7. So high risk 56-year gentleman who is a high risk CA prostate with a Gleason of 7. MRI shows T4 base of bladder's involvement. Dr. Hammad, one question which is important. Prostate cancer, which is involving bladder base versus the prostate cancer, which is involving the pelvic side walls, do they have a different prognosis in terms of, even though by TNM they both are T4?
I consider that the T4B disease, which is going onto the pelvic side wall, is generally an inoperable cancer. The bladder neck involvement is rather difficult to assess. Sometimes you have a large gland which is projecting into the bladder, and it is really difficult to assess whether there is actual involvement of the bladder base, or it is just a large gland which is overhanging the pre-prostatic urethra into the. So I consider some of these patients who do not have a true bladder base involvement are still a candidate, and their overall prognosis would be good if some type of extirpative surgery is done. Mr.
Yes, I agree with you, Hammad, because with this, if there's involvement of a bladder neck, one can do a wide excision toward the bladder neck, and then the only limiting factor is you have to be careful about the ureteric orifices, because you can't go too much toward the trigone side. But anterior and lateral, you can do wide excision of the bladder neck, and then you can do a repair, whichever fish mouth or different types of repair. Well, in this case scenario, like if we are saying T4 tendency here, we're different. We tend not to offer surgery, and they go for hormones and radiotherapy because the likelihood of positive margin is high. And again, it's the same scenario that they end up having positive margin and then needing salvage or enlargement radiotherapy anyway with the positive margins.
Okay, so for the residents, is ADT an option for this patient? Only ADT?
No. I think if he's young, if I'm not right, he was young, wasn't he?
Yeah, absolutely. He's young.
Yeah. No. If you androgen deprivation therapy is only for metastatic disease, if you are not. But these guys who have got locally advanced disease, they can have. In this guy, if they've got Gleason 8, they will have 3 years of androgen deprivation therapy. If they are Gleason 7 intermediate, they will have 2 years. But as such, only androgen deprivation therapy would be grossly unfit patient who hasn't got 10-year survival, and that you are just doing palliative. So that's not an option.
So for these patients, even though as suggested by Dr. Hammad and you as well, that surgery is not in the primary modality for the treatment, that will be radiation plus hormone therapy. So he received EBRT plus hormone therapy, and then his nadir PSA was 0.04. And after 1 year follow-up, his PSA turned out with 3, and he's currently asymptomatic. And so, for the resident point of view, how to re-stage her? Is there a need of re-imaging?
So the suggestions are that imaging and biopsy and MRI scan. Some people think MRI scan. The other says that the PSMA scan should be done. So MRI, biopsy, and imaging, either the PSMA or MRI scan. I think MRI is good for pelvis, but when it concerns, and this patient probably would require abdominal imaging as well. So either you use PSMA or local imaging with MRI and maybe abdominal imaging with CT if PSMA is not available.
Absolutely, Dr. Hammad. Yeah.
Yes, please carry on.
So this is how the guidelines does suggest. But one of the important thing here to highlight for every resident here is the salvage radical prostatectomy after radiotherapy should only be performed in the experience center because of its functional outcomes in terms of incontinence, especially. Mr. Afzal, could you just let us know your experience about salvage radical prostatectomy and what is their incontinence and how they go about after surgery?
Yeah. So salvage prostatectomy after radiotherapy or hair HIFU treatment I agree, is a difficult surgery, and it should be done in centers who are equipped to do it. And it's slightly better with robotic surgery, but yeah, there are high risk of not only incontinence, but especially in cases of HIFU, there's a high risk of rectal perforation because the posterior planes are occluded, and you don't, like the denonvillar fascia, which usually is intact, is with this HIFU and radiotherapy, that is totally like amalgamated or plastered. And there's these patients should be warned of not only incontinence, but rectal perforation needing a colostomy or a primary repair. So both way, it's a difficult operation. Sometimes, we in our centers, if somebody comes with post radiotherapy recurrence, and then we do biopsy, we locate where we can treat it with HIFU, which is it's called salvage HIFU for post radiotherapy recurrence, which is a less invasive way of treating this recurrence rather than salvage prostatectomy.
So, but this would be a low volume disease in one of the lobe. Am I right?
You mean for HIFU?
Yeah.
Yes. Well, HIFU you can offer to both lobes. It's different. You can either do the whole gland or you do a localized HIFU to the area where. But yes, it can be given to the whole gland. Whole gland HIFU is an option after post radiotherapy recurrence.
Okay, thank you. So moving forward, these are the couple of slides to show the residents that how management of the prostate cancer have changed in the last 2 decades. This was the case in 1990 till 2000 for 1 decade, and then onwards I'll discuss. So 62 male who was diagnosed to have a metastatic prostate cancer. He was on an ADT. His nadir PSA was 0.2 for 4 years. Now it's rising up and he's asymptomatic. This is how we used to do, or we used to see how it was done. Anti-androgens, then estrogens, they were either oral or IV. And then once they start, like PSA starts doubling up, increasing in the size, one could have considered chemotherapy. But currently, there's a total paradigm shift in the management of the prostate cancer. So I'll go further. So he is a 60 male, no known comorbids who had a TURP outside. He has a Gleason major 5, minor 4, currently asymptomatic. However, the PSA is 58. And if you can see the images on the bone scan, there is increased pressure uptake, pressure activity on the right pubic ramus. And here comes the prostate, which is like advanced prostate cancer. And you can see easily that there are a couple of nodes in the median sacral and on the right side as well. So how to go about that? So one of the important things to realize that it's not only ADT which you start being a urologist, but it's important to monitor their side effects as well. and the role of bone strengthening agents in STAMPEDE trial and rest of the trials is well mentioned now. So these patients who have bony myths, they're always given this bisphosphonate, either IV or oral. So there are few trials which are mentioned in the guidelines that these trials have really modified the treatment of metastatic prostate cancer. So according to each of these have different criteria to anchor the patients, but there has been a significant improvement in overall survival with upfront chemotherapy plus hormonal therapy, especially in the Chartered or STAMPEDE. So almost on an average 2-year difference, 18-month difference survival was noted with upfront chemotherapy versus without chemotherapy. So this is how the recommendations currently stand up with the metastatic prostate cancer who are patients with the metastatic disease. If they are fit enough, they should be treated with the chemotherapy upfront with hormonal therapy. So coming up to the last case, 65, known case of metastatic Ca prostate. To start with, it was M1B. He has been on ADT. Now PSA is coming up. Testosterone is less than 30. So this is a castration less than 30 or less than 50, but I think guidelines does mention about less than 50. Dr. Hammad?
Yeah, I mean, less than 20, less than 50. These are the two values commonly mentioned. So either one is correct.
So before going ahead, we should always look at these values which are important to us in order to make sure that this patient is CRPC. So for those patients who are CRPC, there are a lot of other options like abiraterone acetate, enzalutamide, and docetaxel, depending on their suitability for these treatments. And these treatments have been modified based on these trials, which are mentioned here in this slide: STAMPEDE, Latitude, Chartered, and Enzamate. And we can clearly see there isn't a significant advantage of adding these drugs. In apalutamide, you can see that 10% of overall 2-year survival benefit and around 8% 3-year survival benefit on enzalutamide. So this was all from my side. Any question from the resident point of view?
So please feel free to ask any question related to prostate cancer, whether they were discussed in these cases or otherwise. If you have any queries, any concerns, anything which is not clear to you, ask them now. You have the pleasure of having Mr. Afzal Imran to address these questions.
Hammad, while the residents are thinking about a question, do you run like a multidisciplinary team meetings for all these cases, especially locally advanced and metastatic? Because the input of oncologists is very important. I mean, we always have in our weekly meeting an oncologist there who helps picking these cases.
Yes, we have started MDT, which we call tumor board, about 5 years back. And we are now at a state where nearly 80% of all our oncological cases are discussed in these tumor board meetings. In fact, this tumor board has become so popular that from within Karachi and even outside, the cases are referred to the tumor board. And thanks to, in a way, thanks to COVID, that our communication using Zoom is so friendly now that anybody can present a case. They just need to send the CD with the imaging, the histopathology slides to us 5 days in advance. And our pathologist, who is a dedicated uropathologist, we have an oncologist who are dedicated to the GU oncology, radiation oncologist, the radiologist. They are all there, and
Right.
they all help. And I absolutely agree. I mean, every case I myself learn a new thing, a new perspective. We used to be fighting with each other and saying, this is ours, this is what we are going to treat. and now we are more in a sharing mode since this tumor board.
That's the way it should be. Yeah, great. Okay. Together, there are questions from residents, which Hammad, we can address.
Yes. So the question about bisphosphonates, their role. So remember that metastatic Ca prostate is a systemic condition, and you have to look at various aspects. ADT in itself is a major cause for significant complications and morbidity, and you need to monitor their health from that perspective as well. It has significant impact on muscle mass, psychological things. So these are something that one should not forget. Bone, as we know, is the main landing site, and you have to take care of, and this just not involves use of bisphosphonates and calcium supplementation and vitamin D, but also changing the lifestyle, because we know that the kind of services which are available in the Western world are not here. You have to explain to them, it's your responsibility, that they should have support moving from their bed to the washroom. And this is the commonest site of fall with fractures, and these fractures are at times catastrophic because of their extremely porous bones. Remember that bilateral subcapsular ochiectomy is a 30-minute local anesthesia procedure, one time only for the rest of their lives. So somebody who's not very keen and is not a candidate for intermittent androgen blockade, it's a cheap option for years to come, and you don't have to be there every 3 months for a shot of LHRH analogs. So these are some of the practical things that you need to take into consideration while treating patients here in Pakistan. Mr. Afzal?
Yeah, Hammad, you have summed it very well. That yes, because here we endorse it, come across elderly population, the patients within 80s, even 90s, and this bone health is important. And it's not only like you would say vitamin D supplements or bisphosphonate, but it's just we have got a program where the physiotherapist gets involved, and then they need to have they get into this exercise program where because that exercise strengthens their muscle mass and bones, and they have got like aquatherapy. If they can't walk, they're down into a pool where they get exercises. And the other important thing is that with this, especially with androgen deprivation therapy, it's different with subcapsular orchidectomy, which is out of fashion here in the West. Patients don't go for that really. But then you can give them a break in between hormones. So they can have intermittent hormone ablative therapy. They can have their 3 monthly injection LHRH. And once their PSA drops less than 1, stop their hormones, give them a break for a few months or years. So keep checking their PSAs, and when their PSA goes up to, you can draw the limits where you want to draw 5 or 10 in double figures, then restarts. But then it helps to regenerate some of their osteoblastic activity and bone strength, bone and muscle mass. So that's another way.
Thank you very much. I totally agree. I think we haven't touched upon one important area, and that is related to the lymph node dissection. So what is your technique for lymph node dissection? Is it standard for all, or you move outside the true pelvis depending upon the stage and grade of disease? So what's your lymph node dissection?
Hammad, with this, the more cases I do, the more I've learned, because I think this lymphadenectomy, or especially, extensive pelvic lymphadenectomy, it's a diagnostic value rather than therapeutic. Once the disease is in the lymph node, you are unlikely to cure it completely by removing whatever number, because you go for 3, you go for external ileal, you go for obturator lymph node and deep nodes. But if you're going higher, which some of these European counterparts or the American would offer, I don't think after a certain limit, when the disease is in the bone, in the lymph nodes, whatever high you go, you are not going to eradicate that disease. They're bound to have micrometastasis. This case report we quoted, the single node para-aortic. So one should draw a limit. So I kind of limit myself to external iliac, obturator, and internal iliac. I don't go any further up. And I don't think so I was ever able to cure somebody who has got a lymph node disease. And one be more higher you go, the more likely complication with lymphocytes and other issues with bleeding. So one should limit yourself. And I only offer lymphadenectomy to Gleason 8 and above. And if with our technique, if we know, because we are sampling all the prostate, I only restrict myself to the side where the cancer is. If the other side has got no cancer, I don't bother taking lymph node from that side.
Right. So I think that's a very important point. But since trust-guided biopsy has a number of fallacies, you can miss out particularly small volume cancers elsewhere. And to our surprise, sometimes when you re-biopsy them, you find a higher grade small focus of even 5, whereas predominantly your 4+3s and 3+4 were the main biopsy samples. So
exactly. Hammad, you will be surprised. We stopped doing trust biopsies some time ago. But when we were doing trust biopsies, there were so many patients coming back with their negative biopsies and their PSA were still high. They came again and again, repeated. And at one time, say 5-10 years ago, there were patients who had biopsies 5-6 times before we picked up, because you're doing a limited biopsy with trust you can do. But with this, our technique, so you don't miss it. If you're sampling, you put a grid, which is a brachytherapy grid. It's got 5mm hole. You put it on the prostate and sample every 5mm. So our histopathologist is happy. He says, do it once, as many you want to do, but don't keep bringing them back. That you sample 12 or 18 and then say, oh, it's negative, we are biopsying again and again, and it comes to same. So he said, just do it once for all under general anesthetic and gives us an answer, cancer or no cancer.
Thank you very much. Any last comments for the residents? We are right on time, so hopefully we'll finish by 7 p.m. So, Mr. Afzal, any last advice?
I think in a way, I would say that we have to, that's a good thing, we have to embrace this thing which you mentioned, multidisciplinary team approach in Karachi is very good. I encourage, I was talking to Professor Rahman in Peshawar that they should adopt that approach. It helps, one person, urologist or oncologist, shouldn't take the whole responsibility. These are complex cases, especially prostate cancer, which is locally advanced or metastatic. So it should have an input from multimodality team or oncologist or histopathologist or radiologist who gives extent of the disease, and then a decision should be made which benefits the patient, and as well as the clinician, you are protected. That it's not solely your responsibility, you miss something and the patient turning back, and because litigation is so rife here in the West that they will say, oh, you missed that kind of treatment, you could have given it to me earlier. So that's a very good approach. And plus, adding this, I think PSMA PET is very good. It's available in Karachi now. And then the next thing, you guys have to move for transcranial template biopsies. And that's the way forward, because a lot of complications with transrectal biopsies, the infection rates, and basically missing how precise you are. You still end up missing significant cancer with trust biopsy.
So thank you very much, both Imran and Mr. Afzal. It was a wonderful session. I've learned a lot from this, and I'm sure our resident must have learned a lot, must have clarified a lot of confusion that is there. So with this, I really, again, thank the team for this night's session. And we move on a little north from Dorset to Millsborough. Mavish Nadeem, she's going to talk about post-prostatectomy incontinence. I can see her. She's already, Mavish, you can share your screen and you can run your slides.
So thank you very much for this wonderful opportunity. I don't have great signal, so I might have to turn off my video if there's any problem in the voice quality or the slides quality. So I'm talking about the post-prostatectomy incontinence today. There is nothing to disclose. The outline of the presentation would include the mechanism of continence in males. We'll be briefly talking about that. Description of the post-prostatectomy incontinence, the management options, including both conservative and invasive modalities, results and complication of various treatment options, and a specific treatment consideration for each modality. So looking at the male pelvis, if we specifically talk about the continence mechanism, there are two sphincteric elements responsible for the continence in males. The internal involuntary smooth muscle sphincter, which is present at the bladder neck, and it is rich in sympathetic innervation, runs from the, it opens during both the spontaneous contraction and induced by the stimulation of the pelvic nerves. And the other set is the external voluntary striated muscle that runs from the prostate to the membranous urethra. So the overall prevalence of urinary incontinence in men is around 11%. But it's fairly rare in men to have urinary incontinence, specifically the stress incontinence, and especially attributable to the prostate surgery or neurological disease or trauma. It is a common complication of radical prostatectomy, regardless of the technique used. There have been various studies that look at different surgical aspects, ranging from the radius sparing surgery to the bladder neck sparing surgery, comparing the open versus the minimally invasive approach, but it is fair to say that the results were comparable. There's wide disparity in the reporting incidence. It is around 3 to 70%. Most of the studies agreed on a figure of around 30%. Around 10% of the research, most of the reports agree on the 10% risk of severe or total urinary incontinence. So why there is a wide disparity? It is probably because of there is no universally accepted definition of the stress urinary incontinence in post-prostatectomy patient. By that I mean, one study could report a continence rate of 90%, but the definition of continence in their study could be use of 1 pad per day. In the other study, there could be a continence rate reported as 70%, but their definition of continence could be use of no pad at all. So when you are looking at the study, it's really important to look at the definition of continence used by that study. But it's fairly known that even if the pad is used for the security purpose, it reduces the quality of life in patients. This is basically to demonstrate that the urinary incontinence get better with the passage of time. So if you see a patient who presents with post-prostatectomy incontinence, say for example, 6 months after post-prostatectomy, it is fair to start them on some conservative management, for example, supervised pelvic floor physiotherapy. And I'll be talking more about that in my next slides. But it's fair to wait up to 12 months. And as you can see in this slide, that some of the studies report that the continence would improve even at 24 months. So it really depends what your patient expectation from the treatment is. And if they're happy to continue on conservative management, then it's fair to continue on that. These are some of the risk factors. Some of we can classify as preoperative factors that influence the continence, and there are some intraoperative factors. The preoperative factors would include the patient's age, so increasing age, increasing BMI, previous voiding dysfunction, previous TURP or any bladder outflow obstruction surgery, prostate volume, disease status and the staging and grading of the disease, In the intraoperative factors, it ranges anywhere from the blood loss during the surgery, blood and neck contracture, as I said, different nerve sparing technique, radius sparing techniques. And as you can see, it's really important to have a surgeon experience. So it varies. It doesn't really matter if it is a minimally invasive approach or an open up. The surgeon experience counts a lot. So a high volume center and an experienced surgeon would have a better result in terms of continence that has been proven from the available evidence. So what would the evaluation of these patients include? So as for any other problem, we have to take a proper history of the patient, starting from their lower urinary tract symptoms, both in terms of voiding and storage, the degree of urinary incontinence, and the use of pads per day, and specifically emphasis on previous surgical history. So apart from whatever approach they have for radical prostatectomy, it's also important to ask if they have any other abdominal surgery, including any previous hernia repair, specifically if they had any mesh, because I will come to that, why is it important? And also it's important to know what is the forward planning for their prostate cancer treatment. For example, are they going to have any radiotherapy? Or is the disease stable? Is there any disease progression? And it's really important to look at the operative notes from the prostatectomy. So you would have a fair idea if you're going for any surgical approach, what you can encounter. On examination, you would look for any scars, marks, any presence of hernia. So if there is a foreskin, any presence of phimosis, and any previous scrotal surgery, because you're going to put the pump there, and measurement of the BMI. All of my patients come with a 24-hour PET. So we see the degree of the leak on that. It is important for the post-operative comparison. They all fill in a health-related quality of life questionnaire. And the standard first thing we have to do is the video urodynamics if we are thinking about any surgical intervention. There is a role of cystoscopy, because specifically if you're planning to do a artificial urinary sphincter in these patients, because you don't want any surprises when you're going to put a sphincter, because if the patient has got any blood and neck contracture or urethral stricture, you would not be able to have a successful result of your sphincter. So it is kind of contraindication. And then after this thorough evaluation, you discuss your findings and the treatment options with the patient. It's really important to understand what is the expectation of the patient from this treatment. So here I present a case of a 56-year-old patient who does not have any comorbid. He had a RALP with a final histology of Gleason 3+4, organ confined disease, undetectable PSA, and he is 18 months post-op, continuing to leak despite supervised pelvic floor physiotherapy, using up to 3 pads per day. So he's really bothered, he wants some sort of treatment. So we have evaluated through history and examination, and this is the urodynamic trace, which is basically showing a very stable detrusor throughout. And then when we ask the patient to cough, so it's really important, sometimes we ask the patient to cough and they won't leak. It doesn't mean they don't have incontinence. It may be the posture, so we change the posture, we make them in the upright position. Sometimes we have to ask them to do Valsalva, and how we do it, sometimes we ask them to blow, but sometimes we have to give them a syringe and we ask them to blow and move the plunger. So you have to do all of the things which the patient would tell trigger this incontinence. And you would see the leak. We usually try to place a sheet underneath the patient's feet, so you can also see some urine leak over there. And it's really important to document that on a fluoroscopy image. So you can see it's a little leak here. And I must admit, in the first instant, we didn't even notice it was so small. So you can see the leak over here. So what we can offer these patients, there are various options in terms of the conservative management. We can talk about the lifestyle changes that will include fluid adjustment, diet adjustment, cutting down on caffeine, physical exercises, weight loss, and smoking cessation. There could be some electrical stimulation that could be in the form of the anal electrical stimulation or TENS. We usually send our patients to our pelvic floor physiotherapist, and they work with them. We at least let them have 6 sessions of physiotherapy before we embark on something more than that. There is some discussion about extracorporeal magnetic innervation. We do not use this in practice. And there is some discussion about the penile clamps. These devices are basically to achieve non-surgical compression of the urethra. So the value of the various approaches is really questionable in terms of the conservative options. You can manage the patients who have got lots of comorbids and their expectation from the treatment is just to stay dry. Using the penile clamp could be risky at times because it can lead to ischemia and necrosis, and so obviously there are some safety problems with that. This is a study that reported and compared various conservative treatment options, and some of these studies report some benefit, especially if you start, for example, biofeedback and pelvic physiotherapy in the preoperative phase and continue on post-op phase. So there's some evidence of the benefit. So periurethral bulking agent, they are supposed to increase the coaptation and improve the urinary incontinence. And in theory, it looks like a very appealing option. There are various materials used in past, starting from autologous fat, collagen, beads, PTFE. Lately, microplastic was used. It's not in practice anymore. And the only available bulking agent at the moment is polyacrylamide hydrogel, which is mainly water and about 2.5% of polyacrylamide. As I stated before, the success rate, depending on what sort of definition they use for continence, is reported up to 70%, but in practice, and majority of the study agreed on a figure of 30% in terms of success. The SAY database report that 38% patients who chose to go down the path of bulking agent chose to go ahead with AUS down the line because they were not happy with the treatment outcome. There's some contraindications, so that include if there is excessive scarring, there is a underlying stricture or stenosis of the bladder neck, and previous radiotherapy. About 10 to 20% patients can end up in having urinary retention and abscess formation. So according to the EAU guidelines, there is no evidence that this option can cure the post-prostatectomy incontinence, and NICE does not support this treatment as well. The other option moving forward is adjustable continence device or non-circumferential compression device. One of them is ProAct, and it consists of 2 silicone balloons which are placed periurethral at the level of anastomosis. I put a video on and I'll see if that works.
Mavish, I think the video is not running. Yeah, it's at least on our screen, it's not running.
It's not appearing, is it?
No, not playing.
Okay. Right, I'll probably just go back to the. Can you see my screen back again?
Yes, we can.
Okay, I'll probably just carry on because it doesn't seem the video. I tried it before as well. Right, so basically the mechanism is that it's a if you compare it from the sphincter is circumferential compression. This is a non-circumferential compression of the urethra to achieve continence. This procedure is performed via percutaneous transperineal route rather than an incision, and it is in the market for a long time. And why it didn't pick up, it's basically of its low success rate. So we generally don't offer our patient this treatment option. The bulbourethral sling, of which the transobturator sling Advance was in market for a very long time, which is on pause in the UK and most of the Europe at the moment. This consists of two transobturator trocar and a self-anchoring polypropylene monofilament mesh. It is considered as a less expensive and less risky procedure. It is considered as a minimally invasive option, where you can see there is some periurethral dissection. I must admit, I haven't done advanced sling myself because when I came to the UK in 2015, during the 2016, this was out of the normal practice. So in terms of the picture, you can see there's this more or less the same mechanism as we do for other transobturator continence meshes. And this is how we anchor it around the urethra. So it is kind of a fixed device, and this is because it contains mesh, it is not used in the practice in the UK anymore. So the large prospective study that look at the cure rate, they have reported it around 51%, and improvement rate in the continence is around 25.7%, but the failure rate is about 22.9% over the period of 12 months. So the results were not sustained. So there's a limited short-term evidence that the fixed male slings cure or improve the incontinence in patients with post-prostatectomy incontinence. And there's no evidence that the intraoperative placement of autologous sling during radical prostatectomy improves return of continence at 6 months. So this basically came up because some of the centers, especially in America, were trying to do both procedures simultaneously. So when the patient is undergoing prostatectomy, they would have an autologous sling. But interestingly, they end up in having more urinary problems than you would expect in a post-prostatectomy patient. So this did not pick up. Now, coming to the gold standard treatment of the post-prostatectomy incontinence management, this is the artificial urinary sphincter, which is in the market for more than 3 to 4 decades, used very successfully, and it reports a success rate of around 90% in patients who did not have radiotherapy in comparison to 70% in patients who had radiotherapy. It's a versatile and effective treatment option. It can also be used as a salvage treatment option in patients who had previous other treatments for incontinence. There have been various modifications, and over the period of time, the success rate have increased and the complications rates have gone down. This is basically a 3-part device that include the fluid reservoir or the pressure regulating balloon, the urethral compression cuff, and the activation pump. So this is how it looks like when it goes into the body with all the connections. And the pressure regulating balloon marked here, in general, we use it with a 61 to 77 centimeter of water pressure. And the cuff size starts from 3.5 onwards and usually lie between 4 to 5 centimeter, but you have to measure it for each patient. This is the background setup, which we have to do prior to make an incision. We have to immerse all these devices into an antibiotic solution. In general, we use a combination of rifampicin and gentamicin. So they're all soaked in antibiotic before placement. And all bubbles are removed from all the tubings, and then we apply the soft rubber shots. So this is the periurethral dissection. In general, we use the Lone Star or Galaxy retractor. We do some careful periurethral dissection. You don't necessarily want to skeletonize the urethra. You have to carefully go around the urethra, particularly on the posterior aspect. And after that, you use the bespoke measurement device, the tape, and you can see this part of the tape is fairly broad, and we have to just regulate around the urethra to make sure that the posterior aspect is all free before you put the urethral cuff around it. So I generally stop here after the measurements, pack it with antibiotic soaked gauze, and then I move on to the dissection in the abdomen. I tend to put the cuff at the very end to prevent any infection, because if I put the cuff before and then I go to the abdomen later on, then it will be exposed to the environment. So I usually after this, I make an incision in the lower abdomen, depending on the side the patient prefer. Whatever dominant hand patient has, usually the right hand. So we go onto the right lower quadrant, more like a hernia incision. And there we place the pressure regulating balloon. So really important to know if the patient had any previous hernia surgery, and you would expect any mesh. If the patient had any surgery specifically with mesh, you might consider putting it on the left side or into fairly around this suprapubic area. This is here the activation pump that goes into the ipsilateral side of the hemiscrotum. And the it's fairly a blunt dissection, we use it either using Remplace or with a blunt dissection, and then we put it under the after the Dartos dissection. So it goes into the hemiscrotum. And once all these three components are placed, we make the connections. The balloon, the pressure regulating balloon, is filled with 23 mLs of either saline or contrast. In general, the recommendation is to use contrast, but we have used both. Nothing specific. The only advantage of having a contrast, if the balloon ruptures or if they had a CT scan, you would know where the balloon is. But in practice, it really didn't matter if your history is properly documented and the patient is aware they have got a sphincter in place. In terms of complications, the chronic patient, as for the pain, is for any other pelvic reconstructive procedure, we give a figure of around 10%. Some series report up to 50% chronic pain. Urethral atrophy in about 2 to 5% patients. Similarly, for infection or erosion of the device. Mechanical failure over the period of 10 years is up to 10%. New onset of urge urinary incontinence in 2 to 5%. And similarly for the wound infection, we give a lifespan of this device of around 10 to 15 years. 10% of the patients might need a revision depending on what they want later in their life. So there's some specific considerations. So before putting the sphincter in, you have to assess the cognitive ability and manual dexterity of the patient. For example, if the patient has some neurological problem or their hand function is not good, then a sphincter is not a reasonable option for this patient. As I previously mentioned about the history of groin or hernia surgery, all these patients, like for any other implant, would carry a sphincteric card. So they would have a sphincter card that can show that they have a device in their body. And that should have the detail of the hospital trust and which consultant they are under, and some contact details, who they should contact. Patients with component of overactive bladder. So this is a very specific group. So if your patient has got a small capacity bladder and they have got some sort of detrusor overactivity symptoms, which are demonstrated on the urodynamics as well, then you have to have a very careful conversation that this treatment would improve their stress incontinence, but it may worsen their overactive bladder symptoms. So it's their choice if they want to go ahead with it. And in practice, what happens, patient want to get treatment for one problem. And if the OAB symptoms persist or they get worse, then they can choose from various treatment options available, including from pharmacological treatments, intradetrusor Botox or sacral neuromodulation. But we need a careful reassessment once they are recovered from the AUS surgery. When you complete the surgery, the device is deactivated for 6 weeks. So again, we have to mention to the patient that you will be completely incontinent after surgery as you were before. And you would not expect any change in your symptom for next 6 weeks until your device is activated. So they get their surgery, their catheter is removed the next morning, and they go home. They would use whatever they were using, pads or whatever containment device, and they come back to clinic for activation. And they should have a contact person. They can get in touch if they have any problem with the device. The other advice we have to give the patient is that in future, if they need any urethral procedure or catheterization, they must tell the whoever is doing the procedure that they have got a sphincter, because that will need a deactivation before the urethral instrumentation. So this is a fairly recent trial, which was a non-inferiority results of post-prostatectomy incontinence in patients who had sling versus AUS, and it reports that the results are fairly comparable. However, you have to have a careful discussion with the patient about the risk factors for both the treatment options. But in general, both options are equally effective. So, what are the other treatment options these patients have? The patient can use the different containment device, long-term catheters, could be suprapubic or urethral, or they can have a major reconstructive surgery if all other previous surgeries have failed. So this is a summary of treatment that shows what options you can give to the patient. So if the patient presents with mild stress urinary incontinence, you can discuss about conservative treatment options. Moderate leak could be dealt with use of sling, but because this is not available, most of the patients in this category would also choose for sphincters. And of course, the patient who have severe urinary incontinence would end up in having a sphincter. So in conclusion, it's really important to have a thorough evaluation with history and examination, quality of life assessment. You must understand the patient expectation from the treatment. It is imperative to do a urodynamics before any invasive surgery. We should try conservative management specifically for patients with mild incontinence. Bulking agent is not recommended or supported by NICE or EAA, and synthetic sling is on pause. So, and because the sling is also out, the AUS remains the gold standard for severe post-prostatectomy incontinence in both patients with post-radiotherapy and in salvage cases. Thank you very much.
Thank you, Mavish, and thank you for a very comprehensive, difficult subject, but you have really done justice to it. You have covered most areas. There are a few questions in the chat box, and you probably can address them on the chat box. We have to move on to the next presentation. So I welcome Professor Sajid Sultan, dear friend, and always support our academic activities. We move from geriatric to pediatrics, and from prenatal to the postnatal to the rest of the life management of this very difficult disease called posterior urethral valves. So over to you, Dr. Sajid. Thank you very much for being here.
Thank you, Hammad. I have my slides. Assalamu alaikum and good evening to all of you. In the next 30 minutes or so, we will try our best to cover this, as Dr. Hammad has already mentioned, a very complex topic of posterior urethral valves, so that you are able to take your exam and answer the questions being asked by your examiner. And at the same time, maybe in the long run, you are able to manage these patients in a better way after listening to this presentation. Well, of course, it's a congenital abnormality and it presents very early in the prenatal life, but its sequelae remains so for lifelong, and it requires lifelong management and follow-up to adulthood. So I will start my presentation with a video which will show you in real time how a posterior urethral valve look like and how it is incised. This is just a thin membrane. There are various etiologies for this posterior urethral valve, but the real etiology is unknown. It is supposed to be undissolved urogenital membrane or some abnormal placement of Mullerian and Wolffian duct and so on. However, there is a membrane which appears like leaflets. Sometimes people say copum, which is congenital obstructive urethral membrane. They say that it is complete, but it makes a hole is made when they put a feeding tube in or a catheter in. There are various theories about it. So this thin membrane lies distal to the verumentinum, as you can see in this video. And it is so thin and poorly vascularized that you can see that this cold knife is visible through this membrane. And these days we incise this valve with the cold knife, which we usually cut at 12 o'clock, and it opens up the space, and the rest over the leaflets are cut at 5 and 7 o'clock. You don't have to be very aggressive in cutting. You can always go back and do a second look so that there is minimum bleeding. So there is another case where we will be ablating the valves with the help of a squashed loop. This is anterior urethra, this is bulbar urethra, then there's the sphincteric area, and we are entering into the posterior urethra where you can see the veru, the elevated neck, bladder neck, which is a kind of impression because of dilated posterior urethra. At the same time, the neck is hypertrophied, and these valves are nicely seen, particularly when you compress suprapubically, they fuse together in the middle and they obstruct urine flow. And again, you can see that the squashed loop is seen through the membrane. So it's a very thin membrane, but it needs to be removed. Unless it is removed, it continues to cause bladder outlet obstruction. And again, we are ablating it with the help of diathermy, about 25 to 30 watts, cutting current, or sometimes for bleeding, coagulation, but mostly cutting. At 12 o'clock, and then 5 and 7. But is that all needed for these patients? That we have removed the obstructing membrane and the patient should be fine, there should not be any problem later on, and then everybody is happy-go-lucky? No, that's not the situation. So these patients can present in many ways from prenatal life to the adulthood or older child at least. They may present at fetus because nowadays more and more prenatal ultrasounds are performed. For initially they were done for gestational age and presentation in live, but now in any developed setup, an anomaly scan is performed around 20 weeks or so, and that's where you can pick up these urogenital abnormalities as well. So they are even visible around 13, 14 weeks or so. These valves are there at 7 weeks of gestation. So they're a very early thing, and they can present in many ways. They can be very obstructive. They can be less obstructive. So there is a wide spectrum of presentation of these posterior valve patients. You can see that these are 2 kidneys in a fetus, and this is a valve filled with urine. Well, what we do that we always ask them as a prenatal ultrasonologist, we always ask the mother to wait and review the ultrasound 30 minutes later. So usually the bladder should be empty within those 30 minutes. But in case it persistently filled, then there is some kind of urological abnormalities. It could be high-grade reflux leading to persistent urine coming back from the kidney, or it could be valve, which is the commonest abnormality or cause of obstruction in boys. But the diagnostic feature could be the dilated posterior urethra, which we also call it keyhole sign. If we see this, then the chances are that it's more of a valve patient. And later on, when in the neonatal life, we do other investigations like micturating cystogram, which is one of the most important investigations. It shows the lateral view and the AP view that this is obstruction here, which could be well dilated post-urethra, then hypertrophied neck, and then irregular bladder. So these are the common presentations of a valve patient on ultrasound and picturating cystogram. They can have reflux, they may not have reflux. They may have one side reflux, but usually they have hydronephrosis and hydroureter. So this is another ultrasound, much bigger picture showing the keyhole sign and hydronephrotic kidneys. So it can present very early, around 20 weeks, or they may present late. So early, they present that prognosis is poorer. And the other finding, which is very important, is that the amount of liquor present in the amniotic cavity. If the adequate liquor, they present later, around 34 weeks or so, and the previous ultrasound did not show this kind of hydronephrosis, then the chances are that the outcome would be better. But if at 20 weeks or 24 weeks or 26 weeks, we get moderate to gross hydronephrosis, low liquor or inadequate liquor, very infrequent liquor, then the chances of a poor prognosis to the extent that you can have a Porter species and Porter baby. So what if you are brought an ultrasound report of such a prenatal ultrasound, then you should be able to do prenatal counseling, which depends on the finding that at what age the baby was picked up on prenatal ultrasound, how much the quantity of liquor, what was the degree of the hydronephrosis, what was the echogenicity of the kidneys. So that's how you can counseling. And what option do you have? In any case, if you are continuing with the pregnancy, one should always advise them that they should have delivery, because in our kind of culture, they are delivered at small clinics, they are delivered at home. So you have to tell them that the baby has to be delivered at a place where they have a neonatal ICU, because there can be many reasons for that. So these are the factors which are prognostic signs, like oligohydramnios, dilated bladder, severe hydronephrosis, which we have already discussed. But for research purposes, there are other. If you do amniocentesis, the urine sodium is less than 100, urine chloride is less than 90, osmolality is less than 200, and beta-2 microgram less than 67. They are poor prognostic. They are favorable prognostic markers for that, but these are not usually done. So what options do you have? One of the options for severe cases in the West, particularly, they terminate the pregnancy. Here, we have to leave it to the parents, but the chances of a grim pregnancy with a stillbirth or neonatal death are high in severe cases. But other options in a specialized center could be vesicoamniotic shunt, intrauterine valve ablation, but these are done in very specialized center and very selective cases. I can't go into detail who are those cases and the details of these procedures in this presentation, but that's what you should know, that in this specialized center, this is being done in very, very selective cases. There is a criteria. Or after 34 weeks, you can easily ask for a delivery, then you don't have the babies is mature enough for to be delivered, and there's no need for continue. But the best way is, if there's adequate liquor, you have a normal delivery, normal vaginal delivery, rather than asking for cesarean section, and that can always affect the newborn, because they have but when there is inadequate liquor, particularly there is a risk for pulmonary hypoplasia, and these babies can be cyanotic babies. That's why I asked you to tell them to deliver in a place where they have neonatal ICU. These cyanotic babies at times may require up to ventilation or at least oxygen support. And then other features such as voiding history needs to be assessed, that they are being well or they are just dribbling, how they need to be examined for distended bladder. If that is so, then a feeding tube needs to be passed or a mini P has to be placed some way, one way or the other. The bladder has to be decompressed. And then urea and creatinine are not important at that stage, because it's the placenta which is taking care of urea and creatinine. The baby or neonate's creatinine is represented after 8 days or so. It is basically the electrolytes, which is a bicarb, acidosis, ABGs, and potassium, hyperkalemia, which are more important at that stage, need to be managed. And then an ultrasound has to be done to reconfirm the diagnosis. The rest of the discussion, I would take you through a journey of one of our patients who is now more than 13 years old, and we have managed from 7 months of age. And we will discuss all the issues related to that. And I just mentioned that the history is very important, examination is very important. And we have a problem that a lot of places the prenatal ultrasound is not done, or even if it is done, they are unable to pick up these abnormalities. Even after newborns, they are delivered at home or at small nurseries, and they may not be that severe cases, they survive and they present late as infants or even as small children. But this baby presented around 7 months of age at our children's hospital in ICH with the failure to thrive, straining at micturition. The sick babies usually present, they're listless, they are fail to have feed, they are not alert, they don't cry. So these are the features at the newborn where they are in sepsis, they are febrile, they can have anything like that. So you have to be vigilant, and that's why if they are delivered at a proper recognized place with a neonatal ICU, these can be managed early. This child was brought to an ICH in a very grim condition. However, they did very well by looking after the child. It was the baby was running fever, dyspneic because of acidosis, not perhaps was pulmonary hypoplasia, and then even have diarrhea. So they did an ultrasound. Ultrasound showed thick walled bladder, partially filled, bilateral distal hydroureter, both kidneys moderate hydronephrosis. So they placed a catheter, they decompressed the bladder later on, and they did the emergency management, provided oxygen, antibiotics, take care of the sepsis, and then they did the MCUG, which showed the same typical picture of a well bladder, dilated posterior urethra, obstruction here, thick neck, irregular bladder, bilateral reflux in this child at that time. They even had to do peritoneal dialysis in order to take care of the metabolic acidosis and hyperkalemia. And their report showed a urea of 190 mg/cent in a 7-month-old baby and a creatinine of 2.1 mg/cent, which is very poor renal function. However, they also did a MEG scan, which was not a very an investigation which have given a lot of information at that stage with the 2.1 creatinine, and usually with bilateral VUR, we ask for the MSA scan, which gives a better relative function. But nevertheless, an isotope scan is at a certain stage is important and mandatory, which preferably in cases of VUR, we do a DMSA scan, or when there is no reflux and hydronephrosis there, we prefer to do a MEG scan with a drainage of the bladder. We have to keep the bladder on drainage because we don't want the bladder effect to be shown on that, and that's where we can assess better. Any stasis or partial obstruction does not mean that it is severe UVJO. So you have to understand these things. However, this isotope scan definitely, as we expected, showed a very poor kidney on the left side and a reduced functioning kidney on the right side. Finally, in a couple of weeks' time, they referred this baby to a 7-month baby to us, which weighed 3.7 kilos, malnourished, and failure to thrive, irritable, anemic, febrile, still sepsis, advanced uremia. The urea was 234, creatinine 3.46, bicarbonate 7, severely acidotic. Sodium was low, potassium for some reason 2.2, but they can present with hyperkalemia. Uncircumcised spine was normal. To exclude that the bladder outlet obstruction could be due to meningomyelocele spina bifida, but it was not there, so it was purely a case of valve, posterior valve. So we did that ultrasound. Because of the indwelling catheter, the bladder was empty, but still we could usually, it was difficult to see bilateral distal hydroureter, but in severe kind of cases and very dilated distal hydroureter, you can even see this dilated distal hydroureter with an empty bladder. Left kidney was decompressed, but right did not. the right kidney showed moderate hydronephrosis with echoes needed. So what we did, we were involved. We involved our nephrology team, infectious disease team, and nutritionists. So usually these patients require multidisciplinary approach. So what we did ultimately after stabilizing the patient, we did a cystoscopy and a valve incision, as you just saw in the video, that how these valves are incised. At the same time, we did a right refluxing ureterostomy to take care of that refluxive obstructive ureter. And with this management, the nitrocreatinine this baby could achieve was 1.7 mg/cent. And the GFR approximately was around 20 or 17 plus. That's the best GFR with this poor renal reserves. Let me give you a little bit of information and discussion about the kind of temporary diversion can be helpful in such cases. If the baby urethra is not dilated enough that we can pass a cystoscope. Usually the cystoscopes are 7.5 French or 9 French are easily passed through. But those who are severely malnourished, then this may not be possible, or you don't have the facility, or they live a longer distance, because when you do a valve incision only, then they need to be followed up more closely in order to see how the bladder is behaving, whether they are not having urinary tract infection, they are emptying the bladder well. So if they live in a far-flung areas, they cannot come regularly, then you can do, but the upper tract got decompressed with the help of catheter, so you can do a block cystoscopy. But if the upper tract do not decompress, that means that the bladder is thick-walled and the UV junction are more severely obstructed. If they are not allowing the kidney to be drained properly, then perhaps the better option in those cases would be to a bilateral ureterostomy. What we did in our case, we incised the valve and we created a refluxing ureterostomy that was done on the right side, basically. And this is a simple way, and you can easily close these ureterostomies later on once the baby develops and is little bit grown, the health is improved, and you can assess the bladder better. They can have arrangement to repeatedly visit the institution for follow-ups. All these things are taken care of. And the usual time is around when they go to school. Before that, they are in nappy. These ureterostomy is drained in nappy. So all you need to take care of the skin. As you can see, there is some excoriation. So antifungal cream or zinc oxide, as you do in other stomach cares, that is needed. And otherwise, if they have adequate renal function, they don't need anything. They should be, if they don't frequently get sick, then their health improves and they gain weight and height and all. If they have severe renal dysfunction, then definitely they have to continue with nephrology care and all kind of support which is needed from nephrology. We'll discuss a little later. Well, when the time has come that you are supposed to close these ureterostomy, or you have not created any diversion, temporary diversion, even then in these valve cases, for nighttime drainage or for the residual urine, because when they void per urethra, even after the valve removal or valve incision, they have a hypertrophied neck, they can have hyperexia, they have poor retrosal contractility. For all these reasons, they tend to have residual urine. When they have residual urine, they distend the bladder continuously. And that bladder get ischemic, and there is more and more collagen which deposit in the bladder. And that leads to valve bladder syndrome, which we will discuss again later on because it's an important area to understand. So in order, and these children, because of renal dysfunction, poor tubular function of the kidney, or refluxing urine coming back into the bladder, or even if there is no reflux, the high pressure bladder does not drain, and there is hydronephrosis, hydroureter. The moment they empty the bladder, the stored urine in the ureter and the pelvic system comes back immediately. into the bladder. So the bladder does not get pressed. In order to take care of that, either if the patient is able to empty the bladder with double void, that should be done, or they should have a appendicovesicostomy according to the Prof principle, that is continent catheterizable channel for clean intermittent catheterization and nighttime drainage. These children are different from the neuropaths. Neuropaths have insensitive urethra, so in neuropaths you can teach them to perform clean intermittent catheterization per urethra, but not in valve patient. Valve have a sensate urethra. It is very painful, so they don't learn. So that you have to create this appendicovesicostomy to take care of this polyuria and residual urine in the bladder and all. So this is a little bit about temporary diversion and later on appendicovesicostomy. So this is another paper from the literature also support this our view. This Indian journal, which says that in the West they pick up because they terminate the poor kind of babies where they have poor renal reserves. The better kidney ones, and they are picked up early. They get valve incision early. They are well managed. They have a good support, society support, and doorstep support, so they can do to the doctor. They can avoid sepsis and all. And they can be managed by valve incision only. But in our society, our kind of socioeconomic condition, our kind of patient population who are much severe, then a lot of them may need some kind of temporary diversion. So what other prognostic factor can help you in this predicting the prognosis of these kind of children? Because about 20 to 50% of them leads to go into end-stage renal disease. And that is one of the argument against the whatever we have achieved in PUV, whatever we have done good to salvage and save these children from dying. They say that what we are saving, we are putting increased number of patients, these severe ones, into renal failure and renal dysfunction. We are putting a lot of socioeconomic burden to the society. But so that is one of the arguments that what up till now we have not been able to take care of the prevent the renal dysfunction and the end-stage renal disease in at least 20 to 50% of these children with severe disease. So the age at diagnosis, this is prenatal diagnosis we are talking about, that particularly that those who present very early prenatally or with oligohydramnios, severe obstructive phenomena with dilated systems, they do not do well in the long run. Some protective mechanism, which I forgot to mention at that time when we were discussing prenatal, that if the urachus does not obliterate early, then that is a protective phenomena. Sometimes the urine leaks from the bladder and they have urinary ascites. Sometimes the urine leaks from the pelvic system and the kidney and they have urinary ascites. These are some of them protective mechanisms because they prevent renal damage. So in some cases, so there's a wide spectrum and they present for many reasons. There's multifactorial reasons. They present in a very wide spectrum. Some do so well, some do. Even in the last week, I was doing a valve incision and he had no hydronephrosis at all. And he was 6 years old, I think, or 4 years old. Up to 4 years old, no valve was incised, but still the only voiding problem was there. Bladder was slightly damaged, there was mild trabeculation, but there was no hydronephrosis. So they can present in a very different manner. But the typical presentations are usually they have these kind of hydronephrosis and bladder dysfunction and upper tract problems and renal damage. So firstly, when they present very early in the prenatal life, around 16-20 weeks, then one of the problems is that their kidney does not develop. That happens with reflux as well. There's renal dysplasia, and they can be total non-functioning kidney with dysplasia, which is also called VURD syndrome with reflux. So, and at the same time, a nidar creatinine at 1 year of age gives you a good prognostic idea. If it is below 0.8 mg/cent, then the chances are that they will not go into end-stage renal disease in the longer run if you protect them well, the bladder and the kidneys and the sepsis. But those who have a creatinine of more than 1.2 mg/cent, like this baby, they have a higher chance, almost 100% chance of going into renal end-stage renal disease at some stage of life. And similarly, we have to, if those who are getting recurrent UTI, they're likely to damage the kidneys, and the bladder dysfunction, as I just told you, the well bladder syndrome is very important. If you take care of the bladder, then the renal dysfunction can be slowed down, deferred, and the borderline cases may be prevented by going into end-stage renal disease. So the same thing has been described in the literature that in the past, 50% of the cases would die in the first year of life or prenatal period, but now with the better prenatal care and early pickup, and this can survive, but they into adulthood, they go into renal dysfunction and same. A lot of literature about well bladder syndrome saying the same things, that you have to do temporary diversion in some cases, or appendicovesicostomy and manage the bladder medically by preventing the residual urine and give rest to the bladder so that bladder can be saved, and that bladder not just help in socially acceptable voiding and continence, and at the same time that bladder will prevent any renal damage or delay the renal damage, at least in the borderline cases. So managing bladder is so important. So this is again a repetition. 3 processes contribute towards well bladder syndrome: polyuria, poor bladder compliance, high voiding pressure, which I've already mentioned, that these children void against high resistance still after incision of the valve or removal of the valve, because they have hypertrophied bladder neck, they have hyperreflexia, which can be taken care of in some cases by bilateral blockers or bladder neck incision. But these are the factors which contribute to well bladder syndrome: polyuria because of tubular damage, residual urine, which needs to be taken care of. So all these factors have to be taken care of to well bladder. Similarly, the same thing, that in the beginning it is a small thick walled bladder which improves with time when you take care of it. It can become a normal bladder, and later on in life, they have the natural histories that they can become large, adynamic, poor, non-compliant bladder, compliant bladder, very compliant, or they may become low volume, poorly compliant bladder. These are the 2 kind of bladder which you would see in posturethal valve. A lot of them at the later on life. So the message is that you have to follow the bladder dynamics by uroflow, by residual urine, by ultrasound, by frequency volume chart, by seeing the upper tract dilatation, and manage them by removing the residual urine, medical management, and keep observing them. You can't leave them after incision. You can't leave them for longer time. You have to regularly reassess, reevaluate, and they can change their pattern. So that is the message. So you can't predict, but you can guide the bladder to a better side by better management. So for those, better management includes education of the parents and growing children is critically important of the bladder management. Don't aggressively push the child towards toilet training, because they are difficult. For them, it is otherwise you will put a lot of psychological effect on them. They may be wetting the bed, but don't mind, don't scold them, because that may be sometimes a protective phenomena, that the back, instead of back pressure on the kidneys, they leak. So once they toilet train, then they may be having a tonic bladder, or as a habit, they may not be emptying it regularly. So you have to ensure adequate fluid intake, not too much, not too less, and void at time voiding, may not feel the desire. So you have to give them a regimen after assessment of the bladder dynamic. What is their capacity? How much pressure is generated at what volume? So that's why the urodynamic, lower tract urodynamics are important at intervals in these patients. And then to empty the bladder, either double void or appendicovasectomy, CIC for the residual urine. And for continence purpose, you can always have home pelvic exercises and all, physiotherapy. In the long run, well, patients have a great evidence of great quality of life, as I've just mentioned, requiring long-term follow-up and active treatment well into adulthood. This pathology requires communication between pediatric and adult urologists. They will ultimately, after 12 years or 15 years of age, they will go to adult urologists with their problems. So they have to have this understanding. That's why it is imperative for all of you to have understanding how the transition takes place. And then as a transition urologist, you will be taking care of them, even if you don't take pediatric urology as your future career. So apart from the urological management and bladder management and well bladder management, those who are with renal dysfunction and compromised renal function, they require nephrological management. So it is a multidisciplinary management. And one should prevent infection, take care of the blood pressure, acidosis. If they are in acidosis, then their bone get demineralized. So you have, and then they can have bladder bowing of the osteodystrophy, bowing of the bones. You have to provide them vitamin D, other supplements, soda bicarb or sodament to prevent metabolic acidosis, take care of the anemia, proteinuria, and avoid exposure to nephrotoxic agents. And then if they are going into end stage, it is better to provide an angio access early. So this is all has to be done by nephrology team. And then you may have to include other disciplines we will discuss in a while. So how they behave nephrologically. When they are small, their height and weight is not increasing a lot, then their creatinine is maintained. Although the GFR was very low from the very beginning, which will further decrease but what happens that the moment they have their increase in height and weight, they are achieving puberty, then this sudden rise in creatinine and they go into end stage. So that's the usual phenomena. So this is the pattern of this child's creatinine from 2008 to 2018. But with good urological and nephrological management, we were able to sail through them for 10 years or so. So he was about 11 years or so when he ultimately went for dialysis, and he became finally end stage. From chronic renal failure to end stage, we could sail him through for 10, 11 years by urostomy, by nephrological management, by bladder management. So we were already involved in this trial, pediatric urologist, pediatric nephrologist, then we involved the vascular surgeon for angio access. And nutritionist was already involved. Then for their psychotherapy, for their counseling, sometimes you have to include psychiatrists and psychologists so that they accept the next part. And they are pubertal, their sexual desires, other factors, they all require a psychological support. They need social worker support for dialysis and transplant workup and donor assessment and donor selection. What are the issues involved? So then the team has to grow further. So this child had an angio access, AV fistula. He started dialysis in 2018, but he became oliguric because once you are on dialysis, whatever urine the kidneys are making, they dry it up. So the urine volume was 100 mils in 24 hours. So he was a candidate for living-related renal transplant. So he required pre-transplant assessment, not for the lower tract, for other things as well. We referred him to our pre-transplant team, and we also assessed him for his lower tract so that his lower tract should be suitable enough and not to damage the transplanted kidney. We did an ultrasound. Both the kidneys were small, echogenic by this time. Bladder volume was just 89 mils, wall thickness was 3 millimeters. The good thing was that bladder was not very thick. We prevented the wall thickness by becoming this bladder into a non-compliant, thick-walled, collagenized bladder by doing a refluxing urostomy. And also cycling of the bladder by peeing him through per urethra by incising the valve. So we did a uroflowmetry. Definitely, this bladder was not challenged. So he could only hold 89 mils, and the Qmax at that 89 mils was not very representative, 7 mils per second. There was no post-void residue because he could reflux, or there was a very small urine. So we did a urodynamic studies to confirm that what kind of bladder is it at the baseline. It was a non-compliant bladder. He could hold 137 mLs, but he had an acceptable voiding pressure. The voiding pressure was not high. We could, at 137 ml, you can judge the voiding pressure. So what we decided, we did a cystourethropy again. It showed a mild to moderate tuberculation, not severely tuberculated. And the wall thickness also showed that it's a 3 millimeter wall, not 6-7 millimeter. 3 to 4 millimeter up to 5 millimeters is maybe acceptable. Mildly dilated right uric orifice, because it was a secondary reflux with diversion and the reflux had gone. You could see that this is video urodynamic. There's no reflux in this. So this normal left ureteric orifice, left kidney was not refluxing from in the earlier times. It stopped refluxing. So that is one thing which you need to understand. This is a secondary reflux. If you relieve the obstruction, then a lot of them, their secondary reflux go away. You don't need to do any kind of sting procedure or reimplantation, or rather reimplantation is one of the horrible things you would do in most of these cases because of the thick walled bladder. Normal anterior urethra was there. We did a right laparoscopic nephrectomy, but we left this ureterostomy stoma and stump. We, for future use as for CIC, because it was not refluxing, and we thought that even after transplant, it would be protective and we can use it for CIC. The patient can use it for CIC. So we left it. And then for a small capacity, we had 3 options. Augmentation cystoplasty with Mitrofanov before transplantation, augmentation cystoplasty with Mitrofanov after renal transplantation, or rehabilitation of the bladder with hydrodistension. Let's try hydrodistension and bladder challenge. So what we did, that this has also been published in the literature, that a lot of these bladders with hydrodistension, they get better. So we tried hydrodistension in this trial. We did bladder cycling, started hydrodistension, injected normal saline 800 ml through the stoma, the ureterostomy stoma. 14 hours, 39 days, tablet oxybutynin was given simultaneously. Frequency voiding charts were allowed, asked him to void per urethra. Gradually, bladder capacity increased up to 300 ml. We repeated the uroflow. This time he could hold to 225 mils with a filling, and the Qmax got better, 12.6. 10 ml was post-void residue, although we blocked the refluxing ureterostomy, and this was not refluxing these days. Then we repeated the video urodynamics, and it shows a much more compliant bladder with more than 200 mils, low pressure with acceptable filling and voiding pressure. So we gave a green signal for transplant for this urinary tract, lower urinary tract, without any augmentation. So that message is very few of these well bladder would require augmentation if they are managed well. So even if they go into any stage, they can take the transplanted kidney safely. And this patient had a transplant which was done on the left side because we were having a right side stoma for safety. And we didn't have a mother or father suitable donor with the HOTA approval and no coercion, no commercialism involved. Maternal aunt was the donor, and a 45-year-old was related, gave the kidney, 1 haplotype 4 antigen match, left kidney taken, graft kidney and then vessels anastomose to IVC and abdominal aorta, ureter anastomose with extravesical Lich-Gregoire method. Suprapubic catheter, that means we left the catheter to the stoma or the ureterostomy, which is being now used as for CIC purpose. So post-transplant 1-year follow-up, which shows the stable creatinine, stable bladder, he's growing well. the frequency wording chart shows that he voids 2 to 4 hour interval, good single stream, no straining, dry day and night, voided volume 110 to 425 mils, which is getting better and better because of the challenge. Nighttime volume was too much because transplanted kidney as well, and they have a tendency to drink a lot. But he could have a nighttime drainage, but what he was doing, he was sleeping for 11 hours and he would get up once and empty the bladder. We don't mind. Either he should empty within his limits of bladder capacity, or he should put a nighttime drainage. So either way, he's fine. He's not damaging the transplanted kidney. This is the uroflowmetry post-transplant, 280 mils, voided volume 244 mils. And a good Qmax and very little 10 ml or something residual urine. So to conclude, posterior urethral valve has a wide spectrum of pathology and presentation, need multidisciplinary assessment and management. Preservation of renal function is an essential part of management. Thorough regular evaluation of valve, bladder, and lower urinary tract is required to provide a safe, compliant reservoir and voiding, particularly in those who don't have any primary diversion or being through urethra all the time. They need much more close watch. So appendicovesicostomy in those for nighttime drainage is a very good safety option. Most valve bladder can be managed medically. Only few require augmentation cystoplasty. Living-related transplant, renal transplant is a successful treatment option for end-stage renal disease and posterior operation. Thank you for your patient listening, and I'm ready to take questions. I hope this presentation benefit you with your exam and later on in your life for managing these valve patients. Back to you.
Thank you very much, Dr. Sajid. It was wonderful, very comprehensive, and I think the way you have taken the case along and explained various parts of management of this complex condition must have made the whole understanding of the subject quite easy for the residents. There are questions in the chat box, and so I think it would be best if you can address them. Let me see if there is any burning questions around here. So people have talked about the timing of ureterostomy and the timing of vesicostomy, and when at the earliest age you can do valve resection.
I mean, if you have the facility, you have a small scope, you can do newborns. And that's being done in the developed world. So if you have a 7.5 scope, which usually, and you can use a Bugby to that. You don't have to have a Colin knife, which usually you use 9 French scope for that. If a 9 French scope can be passed, it all depends how the best, how is the urethra. So, the best management is valve incision, particularly if you have a good upper tract and a reasonably good bladder. But if the child is sick, septic, then initially you do put a feeding tube and you don't, and they come, as we have poor patient coming from long distance, then you have to take decisions accordingly. The vesicostomy can be done again very early, in first few weeks, as soon as the patient is stable for anesthesia, block some vesicostomy, but one has to make sure that when you have placed the feeding tube, the upper tract got decompressed. If they are not getting decompressed adequately, mild hydronephrosis, hydroureter is okay, but they are still moderately or severely hydronephrotic, they're very dilated ureters, there is echos, patient is in sepsis, then you have to do bilateral ureterostomies in those cases. So that's how you will clinically decide. And refluxing ureterostomy, when we do only in those cases where we have a reflux firstly, where we expect that the only valve incision will not do well. And of course, when you have a gross reflux, the residual urine issues, issues of sepsis, you can't do reimplantation in first year of life. You don't want to, and a lot of them can gradually get better, and you do a reversal, a simple reversal. So as a protective mechanism, you can do a refluxing ureterostomy, no harm with valve incision. So this is the way you decide case to case, but as early as possible, you can do it in a neonatal life, in infants, because you want the child to get rid of tubes.
Right. So thank you very much. I am grateful to all the presenters and panelists this evening for wonderful presentation, and throughout the course that they have tried to help all the residents clear a lot of ambiguities and points. I'm grateful to Mr. Naved Afzal from Dorset, who has always been very helpful in our academic endeavors. Mahwish Nadeem from Millsborough. Then we had Imran from AKU in Karachi. We had wonderful presentations. We had very good discussion. And with this, I like to thank this man. You can see him on the screen, I hope. This is Sharif Charania. You probably know, all of you know him. He's the one who keep pestering you, make sure everything happens on time. And he is the backbone of all our academic activities in the Karachi chapter. And I'm grateful to Sharif for all his effort, for working off hours to help us in organizing this course and many other academic activities in the past. So with this, very grateful to all, and have a very good evening and good luck in your examination. So take care and Allah Hafiz.
Thank you.
Thank you very much, Hammad. Allah Hafiz.